Hi everyone, we're back for the second part of Chapter 12, Elimination, and we're going to talk a little bit about dysfunctional voiding. So dysfunctional voiding is defined as a problem of bladder emptying, and we know during voiding that there's contraction of the external urethra. These contractions are in a staccato pattern and often result in intermittent flow, longer time to empty the bladder, and that often leads to incomplete emptying. Or there may be a plateau pattern that's related to continuous sphincter contraction that results in an obstruction of the bladder outlet. So through either of these patterns, the detrusor muscle is used and it can be overactive or underactive. We know that if there is a pattern of incomplete emptying that goes on for a long period of time, that can lead to overextension of the bladder, and then those muscles are not as functional as they should be. As a result of this urine sitting in the bladder, you have increased chance for UTIs, symptoms of urgency, frequency, and then overflow incontinence can occur. The cause of dysfunctional voiding is not necessarily known and thought to be multifactorial and can be related to constipation, urinary tract infections, some structural abnormalities, could be stress or abuse. So it's something to investigate if you're noticing that your pediatric patient is having these issues. So when you're doing your assessment and gathering your HPI, it's important to ask mom and child, if they are old enough, if there's issues with infrequent or cluster voiding, if they are having holding maneuvers where they don't want to void, if there's been any sudden daytime incontinence, if there's new onset urgency or frequency, if the child is having any issues stopping their stream once they start, any issues with constipation, concerns for infection, or any developmental milestones that may impact toilet training. And as we've talked about before, it is important to get as much information as you can from the child, as based on the child's age, the parents may not be quite aware of all elimination patterns. It's important to do a physical exam, and on females to check for any labial adhesions, and in males to check for any meatal stenosis, which can deflect the stream when trying to void. Some diagnostic tests that you may do if there's concerns for UTI, you're going to start with a UA and a urine culture. You may order a bladder ultrasound to see if structural abnormalities are suspected. You may even see with these patients a VCUG, avoiding cystourethrogram, which would be ordered by a pediatric urologist to check the child's urinary tract and bladder under fluoroscopy. You also may notice that a urologist or a pediatric urologist may order a uroflowmetry, which tests the amount of urine voided during urination and also measures the speed of the urination. It can help identify some causes of urinary difficulties. You'll want to consider several differential diagnoses, starting with a UTI, if there's any structural abnormalities, if your patient has a neurogenic bladder, if they could have an asymptomatic vesicoureteral reflux, if there's been any trauma or abuse, or if there's any urethritis. And this could be caused by chemicals in soaps or even bubble baths. So your management is going to be based on on your diagnosis. So if you've determined that there is infection in the urine, you're going to treat for a UTI. You're also inspecting for constipation. So if there's issues with that, you're going to make sure that you treat the constipation appropriately. Many of the issues that are seen with dysfunctional voiding could be due to some bad habits that have developed as the child is after potty training, maybe taking care of these needs on their own. So it's important to educate both the child and the parent on ways that the bladder works. There's an excellent section in the book on box 12-4 called Urotherapy for Dysfunctional Voiding and Enuresis. This gives good information for the parent and the child about how the bladder works, how to implement bladder retraining, giving lifestyle advice regarding diet and fluid intake, monitoring progress, and assessing any bowel issues. I encourage you to look at this section, as these are very common things that you may be doing in primary care and peds. And lastly, on dysfunctional voiding, there is the use of pharmacotherapies. This is considered second-line treatment in combination with urotherapy. These would be medications that would have been prescribed by a pediatric urologist, as the use of most of meds that are appropriate for this are considered off-label. If there's been significant voiding issues, there could be irritation to the bottom with skin breakdown, so it's important to make sure that the skin is intact and try to help healing in that process. And the book recommends using some vinegar sitz baths to help in the healing process. Patient and family education is very important. The goal is to help the child to learn to be responsive to the cues to urinate and to defecate. The goal is not to hold urine, as that can negatively impact the feedback loop back to the brain, and then the child may feel the need to go less and less. Rather, it's more important to the parent to be alert to signs and symptoms of the need to go, and then if there's any painful or difficult urination. If urination is painful, then children are often going to struggle trying to retain urine or to void incompletely due to that discomfort. So early treatment for UTIs is very important. All right, let's talk next about enuresis, which is voluntary or involuntary incontinence of urine. There are two different types of enuresis: primary, where there's been no previous control of the bladder, and then secondary enuresis, where they've been dry for more than 6 to 12 months, and then incontinence begins. There's also a nocturnal enuresis, is when there's incontinence during sleep. If a child has normal daytime elimination without any issues, and then at nighttime wetting begins, this is called the monosymptomatic nocturnal enuresis, or MNE. So some factors that can contribute to enuresis: we know constipation, if there's been any familial history that someone else in the family has had it, neurological developmental delays, any behavioral issues, if the little one has a functional small bladder capacity. You may see enuresis with sleep disorders, if there's stress or family disruptions, if they have polyuria, or they've had inappropriate toilet training. So when you go to begin your health assessment and learn more about the HPI, you're wanting to learn a little bit more about their voiding characteristics, how much fluid they take in, when they take it in, and the type of fluid that they are taking in. It's important to assess if there's been significant drinking at bedtime, and as well if that has caffeine intake. You're wanting to assess for any history of recent urinary tract infections, if there's any issues with enuresis with other family members, learning more about toilet training, if there's been issues, if that's completed, etc. It's also important to know how the family deals with bedwetting, learning more about the patient's bowel patterns, sleep patterns, their overall health, their nutrition, any behavioral issues, and any recent changes in the family or environment. With sleep patterns, it's important to look for any concerns for obstructive sleep disorders or apnea, and important to assure parents that deep sleep is not a cause for nocturnal enuresis. For general health, you're going to want to learn a little bit about their prenatal and perinatal history. Is the child tired? Have they lost weight? Has there been any issues with excessive thirst or hunger, to assess for diabetes? Has the child been diagnosed with any neuropsychological conditions recently, such as ADHD? On physical exam, you're going to look at external genitalia, if there's any concerns for fecal impaction, looking at the lower back for dimples or hair tufts, and then also assessing for neurological functions and doing deep tendon reflexes. With any child that presents with enuresis, a urinalysis is always recommended to rule out a UTI. When you're considering what your differential diagnoses could possibly be, diabetes, of course, is up there at the top of the list. Diabetes insipidus. Could there be sickle cell disease? Sorry about that. I was trying to turn off my email and apparently did not turn off the audio. You'll want to assess for structural anomalies. If there's constant leakage, then you may be looking for an ectopic ureter or a vesicovaginal fistula. You need to consider, could there be issues with calcium in the urine, hypercalciuria. You'll be ruling out obstructive uropathy, vaginitis, and sleep apnea. So once your diagnosis is made, you're going to want to try to offer management, and the most important goal for that is to establish normal bladder function. With that, that's going to help prevent any physical or emotional or psychological complications. You want to treat for any underlying causes first, and then you'll begin to address behavior modification. This may include medication use, treatment of comorbid or organic conditions, or a combination of several different modalities. Urotherapy is important, as like we talked about in the previous section. Look at box 12.4 in your book on techniques to help with urotherapy. It's important to establish regular voiding schedules. It's important to address any daytime urinary dysfunction and constipation before trying to treat any nocturnal issues. There are enuresis alarms out that will sound when the padding on the bed gets wet. It's important to use this device when there's good commitment on the part of the parent and good support by the primary care provider. Medications may be used in combination with urotherapy and alarm therapy, but it is not curative. It usually has a high initial success rate. Unfortunately, the drugs are very expensive, and there's a high relapse rate when the drug is discontinued. There is a good table in the chapter, table 12-4, that discusses drug therapies for monosymptomatic nocturnal enuresis. I encourage you to look at that. And lastly, with these kids, it's important to be aware that there can be self-esteem issues. These are kids that may not feel they can go spend the night at a friend's house or spend the night at grandparents' house. It's important to keep the situation as positive as possible for them, as they may have poor self-esteem. And then, of course, doing patient and family education, you want to provide supportive and proactive education and positive reinforcement for the child. It's important that the parent is aware that the provider is committed to helping the child to remain dry too, and this is a joint venture for both of you. So I believe that is at the end of chapter 12 and on our elimination chapter, and I appreciate your time. Thank you.